Usually when we talk about AI in medicine on this show,
Mm-hmm.
it's all about the high-tech diagnostic stuff. Algorithms finding tumors in X-rays that human eyes miss, or, folding proteins in seconds. Very sterile, very hard science.
It is. It's usually about raw processing power and pattern recognition.
But today, we're looking at the messy side of medicine, the human side.
Yeah.
We're diving into a paper from the 𝗕HI-26 conference with a title that it instantly grabbed me. It talks like a patient, but feels different.
It's a great title, a really great title, because it highlights a specific failure. We aren't talking about diagnosing cancer here.
No.
We're talking about teaching medical students how to talk to people, how to walk into a room, build rapport, and get a history from a scared human being.
Which is, arguably the hardest part of the job.
It's the art of medicine, right, as opposed to the science.
So the setup here. Medical schools have traditionally used what they call standardized patients, or SPS, to teach this. And before we get to the AI, we kind of have to understand the status quo. Because I always just assumed these trained actors were the gold standard. You hire an actor, you tell them you have a migraine and a bad attitude, and the student has to deal with it. It sounds perfect.
It is the gold standard, but it's a flawed one. And a paper does a great job of breaking down why students actually find these interactions frustrating, and not just because of scheduling or cost.
Right. They talk about the guessing game.
Yeah.
This really resonated with me. The idea that talking to an actor feels like playing, I don't know, an old point-and-click adventure game.
Yeah, where you're just hunting for keywords.
Exactly.
That is a huge complaint. See, the actor has a script. They have a checklist of symptoms they're allowed to reveal. But they're often told not to reveal them unless the student asks the specific magic question.
So if I ask, how is your chest? They might say, fine. But if I ask, do you have any radiating pain?
Then suddenly,
Right.
oh yes, in my left arm. And that trains the student to focus on prompt engineering the human rather than just having a natural conversation.
They stop listening. They just start trying to unlock the script.
It becomes a logic puzzle. It's not a clinical encounter anymore.
And then there's the physical limitation. You can't actually examine an actor.
You can't. If the scenario is, say, acute appendicitis, the actor can pretend to be in pain. But if the student presses on their abdomen,
It's just going to feel soft and normal.
it's going to feel normal. The actor can scream. But that tactile feedback, the board-like rigidity of a real acute abdomen, it just isn't there.
So the student is faking the exam. The actor is faking the reaction.
It's a double layer pretending.
Which brings us to the tech promise.
Yeah.
The logical leap was, okay, humans are expensive. They're physically limited. Let's use large language models.
Of course.
We have chatbots that can pass the Turing test. Why not just make an AI patient?
And that's what a lot of schools started trying. But this paper reveals what they call the empathy gap.
This is the core conflict. It talks like a patient, but feels different.
The students in this study, and you have to remember, these were students in their clinical years, so they've seen real sick people.
They know what it feels like.
They know. And they reported that talking to a standard LLM just felt hollow. It was too fluent, too polite.
It lacked that relational grit of a real encounter.
Exactly. It felt like customer service, not a medical crisis.
So instead of just tweaking the prompt, the researchers sat down with these 12 experienced students to co-design a system that actually works. And what I love is that the students didn't ask for better conversational skills.
No, they didn't.
They asked for better structures around the conversation. They identified 6 key needs.
And the first one is a direct response to that guessing game we were just talking about. They called for context matters, specifically about something called mode selection.
This is the distinction between OCE mode and daily practice.
Right. And OCE, that's the Objective Structured Clinical Exam. That's the high-pressure final.
Time limits, no help, strict grading.
All of that. But the students pointed out that you can't really learn in that environment. You can only perform.
It's the championship game versus the practice scrimmage.
And this is where the whole fidelity argument gets interesting. We often assume that for a simulation to be good, it has to be 100% realistic all the time.
Sure.
But the students argued for goal-aligned fidelity. Sometimes, low fidelity is actually better.
How so?
Well, if I'm learning a new diagnostic pathway, I don't want the stress of a timer or a screaming patient. I want to be able to pause. I want to rewind. I want the AI to break character and give me a hint.
That seems counterintuitive, though. I mean, if the goal is to prepare for the chaos of the ER, shouldn't you throw them into the chaos?
Eventually, yes. But if you throw a novice into chaos, they don't learn, they just panic. They need what educators call scaffolding.
Oh,
The students wanted a system where they could toggle that chaos on and off.
that makes a lot of sense. Okay, let's move to the second theme, which I think is my favorite because it highlights how dumb text chat can be for medicine.
Right.
Information release.
The jaundice problem?
Yes. Walk us through the jaundice problem.
So, jaundice is the yellowing of the skin and eyes, usually means liver trouble. In real life, a patient walks in and the doctor sees it instantly.
Before a word is even spoken.
Before a word is spoken, the diagnosis is started. Visual processing is immediate.
But in a text-based AI chat?
The screen is blank. You just have a chat box. So the student has to literally ask, is your skin yellow?
Which is a ridiculous question to ask a human being.
It's absurd. And the second you have to ask that, you've broken the immersion. You are no longer inhabiting the role of a doctor.
You're playing a text adventure.
Exactly. The students argued that if a symptom is visual, it must be presented visually, immediately.
So they don't want to play 20 questions.
No. They called for policy-driven information release. If the condition is visible, show it. If it's something found in a lab test, hide it until the test is ordered. Don't make me guess what I can plainly see.
And this bleeds right into the third theme, which is that medicine is fundamentally physical.
Yes.
Medicine is more than chat. The paper talks about the evidence-gathering gap.
This is the biggest failure of current AI chatbots. They treat medicine as a purely linguistic exercise, but a huge part of the job is the physical exam.
So they wanted multimodal interaction.
Right. They designed a body map.
A body map.
Yeah. Imagine a graphical representation of the patient on the side of the screen. Instead of typing, I inspect the knees, which is so cognitively jarring, you click the knees.
And you get feedback.
You get data. You click the knee, and maybe you get a little video clip of a reflex test or a text description that says swelling. You click the chest.
You hear an audio file of wheezing lungs.
Exactly. See, that changes the brain activity. Typing check lungs is administrative. Listening to a sound file and identifying a wheeze is clinical.
It shifts the cognitive load from how do I phrase this command to what does this sound mean?
Precisely. And they took it a step further with ordering tests. They wanted to see the cost.
I saw that. Total cost, $100.
And it accumulates. It forces the student to think, do I really need an MRI for a headache? Or should I start with a physical exam? It adds that constraint of resource management, which is very real.
Okay, now, despite these features, the students admitted they still felt anxiety talking to the bot. Theme 4 was the safety net. Why are they nervous? It's a machine. It's not going to judge them.
You'd be surprised. There's a performance anxiety even with AI, specifically around what they call breakdowns.
Breakdowns.
Students are terrified that the AI will misunderstand their accent or they'll phrase a question poorly and the AI will just hallucinate an answer that derails the whole session.
Or give the classic, as an AI language model, I cannot answer that.
Which completely ruins the simulation. So they wanted a hybrid input. They want to speak to the patient voice as primary, but they want a text backup and a hint button.
Is that cheating, though?
In an exam, yes.
Really?
In practice, no. It's a cognitive crutch. If they get stuck, they can type cough, and the system might suggest, are you asking about the duration or the nature of the cough?
So it keeps the flow moving?
It keeps the learning from stalling out just because the student had a brain freeze.
Okay, so we have the interface. Now we need to know how we did. Theme 5 is feedback. And this is where things get a little controversial, for me at least. They proposed a trust meter.
Dual loop feedback.
Right. Loop 1 is real time. A bar on the screen that goes up if the patient likes you and down if you're being a jerk.
Mm-hmm.
I have to be honest. This sounds dystopian. Are we gamifying empathy?
I just need to say the sorry word to get my trust bar to 80%.
That is the danger, absolutely.
Mm-hmm.
You risk training students to optimize a metric rather than feel a connection. But
Yeah.
hear out the counterargument.
In a real interaction, there is a trust meter. It's just invisible.
You mean the patient's facial expressions, their body language.
The body language, the tone of voice, the eye contact. Experienced doctors read this constantly. Students are often so focused on their medical checklist.
Did I ask about allergies? Did I ask about smoking?
Exactly, that they completely miss the fact that the patient has crossed their arms and just stopped answering.
So the digital trust meter it's training wheels for reading the room.
That's the hope. It externalizes the patient's internal state. If you interrupt the patient and that bar drops 10 points, you learn very quickly. Don't interrupt. Eventually, you take the training wheels off.
And the second loop, the post-session feedback.
The cheating paper! This is brilliant! Students want a report that links their specific mistakes to the exact page in the textbook.
Well, that's good. Not just you failed, but you failed because you missed this specific drug interaction. Now go read page 402.
It closes the learning loop immediately. It transforms the failure into a targeted study plan.
Okay, finally, theme 6, the human variable. We touched on this. The AI is just too nice.
Effective computing. LLMs are trained to be helpful assistants. They are polite, compliant, and logical. Sick people are. Often none of those things.
The angry grandma scenario.
The students specifically requested patients who are difficult, a patient who is screaming in pain, a patient who's stoic and refuses to talk, a patient who has been waiting 3 hours and just hates you before you even walk in the door.
Why would they subject themselves to that?
Because that's the job. It's emotional labor. If you only train on polite robots, the first time a real patient yells at you, you'll freeze.
Right.
You need to practice de-escalation. You need to practice managing your own frustration. You can't code that into a standard ChatGPT prompt easily. You need a system designed to be resistant.
So we've got these themes.
Yeah.
But the paper didn't just list them. They built a workflow. I want to walk through this because it really visualizes the future of medical training. Let's say I'm a student. I sit down at the computer. What happens?
Okay, so step 1, mode selection. You choose practice mode. You want hints enabled.
Got it.
Step 2, history taking. You start talking to the AI with your microphone. The patient appears on screen. Maybe he looks a bit flushed. You ask about his symptoms. If you stumble, you use the hint button.
And I'm watching that trust meter the whole time.
You are. You see it dip when you ask a blunt question, so you apologize and it goes back up. Then step 3, virtual exam. You stop talking for a second and you click the body map. You click on the chest. You hear crackles in the lungs.
Okay, so now I have a suspicion. Pneumonia.
Step 4, test ordering. You order a chest x-ray and a blood panel. The system dings. Cost $450. You wait a simulated few seconds and the results pop up. White spots on the lungs.
Confirmed.
Step 5, differential diagnosis. The system asks you to rank the likely causes. You drag and drop pneumonia to the top, bronchitis to second.
Then I treat him.
Step 6, treatment plan. You prescribe antibiotics. Then, step 7, performance analytics. The session ends, you get a score, 85 out of 100. It tells you you diagnosed correctly, but you forgot to ask about drug allergies. If this were real, you might have killed him.
Wow. And step 8.
Knowledge quiz. The system instantly generates 3 multiple-choice questions about pneumonia and antibiotic allergies to lock in that knowledge.
It's a complete loop.
Yeah.
From conversation to diagnosis to treatment to study.
And that brings us to the big takeaway here. The real insight in the paper is this shift from conversational realism to instructional usability.
Oh, man.
Meaning we need to stop obsessing over whether the AI sounds exactly like a human. That's the wrong metric. We should care about whether the system is usable for learning. Does it allow me to inspect the body? Does it give me feedback? Does it let me practice?
It's like a flight simulator. It doesn't need to serve you real peanuts and bad coffee to be a good simulator.
Right.
It just needs to get the physics of the plane right.
That's the perfect analogy. The empathy gap isn't about the AI having feelings. It's about the simulation providing the right cues so the student can practice having feelings.
It really reframes the whole AI replacing doctors debate. This isn't about replacement. It's about preparation. It's the gym.
It's deliberate practice. You do your reps on the AI so that when you touch a real human, you aren't thinking about the checklist. You're just present.
Which is what we all want from our doctors.
Absolutely.
But I want to circle back to that trust meter one last time before we go. Because while I see the utility, it still nags at me.
The gamification concern.
Yeah. If we raise a generation of doctors who learn empathy through a progress bar, does that change the nature of the connection? We're essentially quantifying the unquantifiable.
It's a valid fear. I mean, there's a risk that students learn to hack the interaction, saying the right platitudes to maximize the score without actually internalizing the care.
They could become technically proficient at sounding empathetic while feeling nothing.
A sociopath simulator, if you will.
That's a dark way to put it, but yes.
The challenge for educators will be to ensure that the AI is a bridge to human connection, not a replacement for it. The map is not the territory. The trust meter is not the relationship.
Well, next time I'm at the doctor's office and they look at me with deep concern, I'm going to wonder if they're just watching my internal health bar go up.
Let's hope they're just good doctors.
Indeed. A fascinating look at how the sausage is made, or rather, how the doctor is made. Thanks for walking us through this deep dive.
My pleasure.
And thank you for listening. We'll see you in the next deep dive.